Hi, this is Ellie Fishman, and welcome to Facebook Live. Hopefully, everybody can see me. Um, home. See all the junk behind me. And like to welcome everybody and hope everyone is doing okay. I know it's kind of a hectic time for everybody. It's somewhat between what seems to be a Groundhog's Day versus the Twilight Zone. So I hope everyone's doing okay and everyone's healthy and seems to be some progress in terms of surely flattening the curve. Some good news with some of the new medications coming along. Good news from a company like Pfizer, who beginning to test, will test big numbers of vaccines. So hopefully the sheer madness can be kind of controlled a bit. So I think probably most of you in radiology, I don't know about the worldwide, but surely in the US, volumes are down 50 to 70%. So we're not as busy. The acuteness of the patients is higher. The techs are doing an amazing job everywhere. I can see that uh, the opportunities for doing great things now it's amazing. RSNA abstracts deadline was yesterday. Hopefully RSNA will happen. I would bet 90% of the abstracts for RSNA are going to be on COVID-19. There was a thing from the Paul Allen Institute that developed software to basically try to look at the COVID patients or articles, because as of last week, there are over 50,000 articles, which is somewhat staggering because, is there information in there that you can learn things from? We see a few articles, things like radiology. I've done a great job. So I know that it should be fun. I see a lot of people online. I see people from Laura from North Carolina and Nepal and Mexico and Colombia and Lancaster, PA. So welcome everybody on board. And today's talk's on CT angiography. One other thing, just to let people know, and probably many of you do know that for the past 5 years, we've done a speaker series at Hopkins, and we've been able to publish a lot of the articles based on what the speakers say in JACR. We would meet about once a month, about 7 or 8 times a year at Hopkins, and that would be the talk. The people would spend a day with us. Now, obviously, that's not possible. They can't spend a day with us, and we can't get together as a group, but I've been speaking to people, and people have agreed to have seminars online. So instead of coming to Hopkins and speaking, they're going to speak on Zoom. So our first speaker today is David Spitzkey. David's an expert in many things, but he's the chief evangelist for Alexa and Echo. And, and his expertise is in voice. And these days where we don't want to touch anything, just think about the value of voice, retina, but voice would allow you to do a lot of things, picking up the phone, not touching things, running your computers, pressing the elevator button, doing all sorts of things. And voice can do that. If you have an Alexa or if you have a Google assistant, you kind of know just the tremendous capabilities. And it's been progressing, but I think events like this, which really are game changers, will really change a lot of things much faster. Communication to patients, things like that. And he's going to speak about the concepts of voice and what it's been doing, really where things are in terms of the cutting edge of things, but also really focus it on what they're doing and what they're looking at and what other people are doing in terms of in this pandemic crisis. So it should be very, very exciting. And it's 3 o'clock promptly. I know he's going to speak for probably about 30 minutes from his basement, like many people. And then what's going to happen at that point is he's going to do Q&A. And he told me yesterday, I will stay online as long as people have questions. So that's really kind. I know David travels probably 90% of the time, lecturing and speaking and presenting and teaching. And so he's home with his family. And because no one is traveling. So in that regard, I think he almost was happy to be able to do it. And he indeed was happy. And so we're really excited about that. So that's 3 p.m. today, and that'll be on Zoom. The topic today is on CT angiography. So I wrote down a few notes. We do a lot of CT angiography. So CT angiography, it's kind of a funny term. It's like vascular CT. Well, the truth is every CT study we do is really a vascular study. When we do some non-contrast, so maybe those are not the CTAs, but When I talk about CTA, it's studies where you're really trying to define the vascular map for a range of reasons. Now, the truth be said, we've made this point on many of our lectures that one of the things people tend to underestimate is how much information you can see on a CT scan if you look at the vascular map. So things like tumor detection, whether it's looking at the liver or pancreas or kidney, then tumor, not just detection, but tumor staging. So surgeons want to know, is there a pancreatic mass present? But then they want to know vascular involvement. So that becomes the staging. What's the portal vein? What's the SMV? What's the celiac? What's the SMA? What's the hepatic artery? What's the GDA? Those things affect what we do, how we do them. So Appleby procedures have come along with good vascular definition. Surgeons do reconstruction of hepatic arteries or short segment of venous occlusion or venous involvement of PV or at times proximal SMV. So it's really a critical thing of what we do. That's oncology. And again, you could talk about that in liver and kidneys in terms of staging. Then we have this whole big area of vascular, like the aorta, which is anywhere from rule out dissection, whether it's atherosclerotic disease or it's trauma. We're looking for ductus region. We talk about CTA, abdominal aorta. We talk about evaluation of aneurysms. We talk about staging aneurysms. We talk about planning endovascular stent procedures. We talk about once a patient gets a procedure, is there any complications related to the stent? We talk about vascular on both the arterial side, typically is what we talk about, but we do a lot of that with the venous side as well, not just venous with IVC, but renal veins, femoral veins, iliac veins, you name it. We do a lot of stuff there as well. We talk about CTA in the chest. So if I wanted to think about the chest, I would say, well, pulmonary emboli is a CTA study. Vascular malformations are CTA studies. Staging patients pre-op for resection of lung cancer could be a CTA study. We talk about runoff studies. So whether it's peripheral vascular disease, CT is really good. Bone removal, dual energy CT becomes very critical in that regard. And then we talk about things like trauma. Vascular imaging is very critical in trauma, looking at the extent of injury, looking at vascular injury. We talk about things like GI bleeding. So we do lots of GI bleeding studies, and for whatever reason, there seems to be a lot of them in this COVID era. So looking for the presence of bleed, typically we look for lower GI bleeds beyond the ligament of Treitz, but I gave some case conferences yesterday at our internal conference talking about bleeding proximal to the ligament of Treitz, where you can pick up duodenal ulcers or gastric ulcers or possible masses as well. So that indeed becomes something to think about as well. Now, in terms of CTA, so I wrote down a few things because we don't have that much time to talk about it. Now, I will say there are a lot of lectures. If you look at the CTisus lecture series on the iPad, iPhone, whatever, there's a lot of good lectures there, and there's a lot of good lectures on CTisus, the website. But things I always stress are the protocols. So the key thing is you need good vascular access. If you don't have good vascular access, you're going to have a problem, because to do a good CTA, timing and delivery of contrast is everything. So we talk about injecting 4 to 5 cc's. 5 cc's is ideal. We rarely do more. Maybe for coronaries, we do 6 cc's, but 5 cc's, roughly 100 cc's of contrast, depending on the app, 90 to 120. We typically never give more than 120. So that becomes very critical. And then we talk about injecting and then the timing of the injection. Do you have a preset delay, arterial 30 seconds, venous 60? That often works very well in younger patients, but in older patients, you have more of a challenge, because in older patients, what happens, of course, is that the patient's cardiac output is lower or decreased. And then what happens is the arterial phase may be much later at about 40 seconds, and the venous phase becomes much later as well at 70 or 80 seconds. So often we'll do triggering. If you use triggering, you want to trigger closest to where you need to be. So if you're looking for the lower extremities, you're doing a runoff study, you want to do the triggering at the aortic bifurcation, or maybe even a bit lower. Triggering in the thoracic aorta is not going to help you. If the patient has poor cardiac output and it's slow flow, you can really screw things up. There are certain tips I do have in regard to that. So we're doing a runoff study, often, particularly with people with peripheral vascular disease, even forgetting the same patient. Left to right can be different because of multiple stenosis, and often the flow is slow, and I've seen people call occlusion beneath the popliteal. What you need to do routinely on older patients, almost most patients, get a second run from the popliteal behind the knee down about 30 seconds after you finish the first run. So if patients have slow flow, I've seen many cases where I would have read it as vessels have no flow. You wait a few more seconds and you see perfect flow with some disease, of course, in those vessels. So that becomes very important. Critical thing with CTA, like with anything, patient positioning, make sure the patient's comfortable. This is particularly true in the trauma patient. Don't force people's arms over the head or by the side. The big thing to me is don't move. We can do bone removal with dual energy CT. Now, in terms of CTA, dual energy is really good if you have it. And the reason for that is, the main reason to me is the ability to do easy bone removal, particularly in the carotids, head and neck region. Regardless of the application or technique you have, it really becomes very important to have a dual energy technique. And I know dual energy is typically on the higher end scanners, but now it's going down to many of the other scanners as well. So that could become very important as well. So I would recommend people do that. If you have it available, there's no downside. It saves a lot of time doing dual energy. Dual energy can also be a way of decreasing the volume of contrast you use. Patients with borderline renal function, or patients where the opacification is not that great. The dual energy, by using, let's say, 150 and 90, use the 150, you can pick up the vessels a bit better. So that becomes very, very important. I mentioned in runoff studies the importance of getting a second run from beneath the patient's knee downward. In terms of protocols, when do you do dual phase imaging versus single phase? I think in oncology, surely we typically are doing dual phase imaging for the obvious reasons. You're looking at the arterial and venous side. Some things fill early, some things fill late. You also can characterize tumors better by having dual phase imaging. We do dual phase in GI bleeders because sometimes the best bleeding is seen on the venous phase, not the arterial. And yes, you say, what about non-contrast? We don't bother because every time you have a bleed, it changes between arterial and venous. We also know that the patients who the bleeding increases between arterial and venous are more likely to have positive angiograms. So that is a very good way of doing the studies. And if you don't do that, I think you're going to miss a lot of things. So that becomes important to us as well to do that. I think also in terms of people ask me about positioning, supine prone, we do everything supine. Coronary arteries, I mentioned, is the only thing we typically do a 6 cc per second injection rate. Other things to talk about once you have the data. You could look at slices, and slices are okay sometimes for measuring the size of abdominal aortic aneurysm, perhaps, or a thoracic aorta. But you realize, of course, that when you have so many images, when you're doing a runoff study, you have 3,000 to 5,000 images. And the clinicians also, even if you would read every image, they don't want to see that. They want to see vascular maps. So things become very critical. I mentioned dual energy is good for bone removal because you want to be able to do reconstructions. Now, I routinely do both MIP and volume rendering. MIP is very good, obviously, is very bright, looks like an angiogram, makes it easy. Volume rendering can also show soft tissues and bone. And volume rendering at times gives you better branching patterns. We've also been using cinematic rendering, and that works very nicely as well. So you want to be very careful to make certain that you have someone who knows how to do the CT angio 3Ds. And that's in oncology, and that's in vascular imaging, and that's in the chest, because there's so much more information. Articles have shown 25 to 30% difference in diagnosis, difference in staging. And again, as a value added, the referring clinician wants to see the 3Ds. They don't really want to be sitting there looking at the patient's thousands of slices. That really is not good. So let's see. A few other things. Now, first of all, I'm at about 15 minutes, so we're going to be running out of time soon because I like to keep these under 20 minutes. So if anyone has any questions, this is probably a good time to ask the questions. A very good time to ask questions. Other things to think about in terms of CT angiography. I think you want to be very careful in terms of looking at the images. If you do CTA right at 5 cc's a second, the density of the contrast can be in the 400 to 500 Hounsfield unit range. So when you look at the images, make sure you change the window setting to, let's say, 500 over 50, so things aren't too bright. If things are too bright, you can hide the sections. You don't really see the calcifications. You can blur, clot. You can miss a lot of things that indeed become very, very important. So you really want to do that. That becomes very, very important as well. In terms of CT angiography and some of the things that will be changing, I think one of the things you're going to see is more CT angiography using different visualizations techniques. We were starting to use the HoloLens with Microsoft through Siemens. You put the goggles on, gives you really good 3D display, sort of this real-time, real conceptual 3D with augmented reality, and using that with cinematic rendering. And that's very exciting. Of course, with this COVID nonsense, we've not been able to do that, so that becomes more of a hassle. So, but we will get there soon. So I think that's not going to be, that's just the delay. I think one of the challenges I think everyone knows with this COVID is most of the labs are closed. Like we're doing the Felix project, we're able to do a lot of the imaging from home, and we're writing some of the articles and trying to keep very focused in addition to doing the clinical work. But a lot of the labs at Hopkins, all the labs are closed unless it's COVID related or someone can come in to feed the animals. So it's really hurting a lot of the research. As you know, a lot of the clinical trials are not being done. You can't enroll patients. So hopefully over the next few weeks, as things become a little bit more stable, as we can do elective surgeries, that will be coming back into place. But as I say, volumes are down, but I think volumes will pick up surely second half of the year, but maybe as early as the June timeframe. In terms of the 3D, we typically, some of the 3D is done immediately, but a lot of it is done after. So you basically have one report that talks a little bit about the vessels, talks about some of the extravascular findings that you see, and then a 3D report really targets the imaging, creates the specific images. For the clinicians, I create the images that I know they want to see. So if I'm doing a pancreas, I'm showing the celiac, I'm showing the SMA, I'm showing the GDA, I'm showing vascular involvement, I'm showing the portal vein and the SMV, I'm showing the tumor, I'm showing the relationship of tumor to vessels, the relationship of tumor to the liver, any type of invasive changes that are going on in terms of spleen, in terms of stomach, in terms of liver, in terms of duodenum. So really, when I take the images, it's when I'm doing my report. So it's kind of like I'm creating a narrative. I think it would be interesting. I think, in some sense, if you could speak fast, what some of us can do, it'd be great to do a narrative. People, I think Bill Glenn 30 years ago was doing a narrative report where the report has the images and the voice. There probably will be something like that. It's not taking effect because people want to read things faster, and you have a report verbally, it's hard to get to the chase, and some people would go on and you go crazy. So that's not happened, but probably some way in between with images, as you have better reports, not just basic typewritten reports. So that becomes important. Now let's see, anybody else? I can only see a few questions. One of the things we have on Facebook Live now, there's a new format, so it's kind of interesting. Some things I could see before I can't see now. But so those are the main things I wanted to go over. We'll come back again and do a little bit more on CTA. And I think what I'll do in the future is probably do specific applications, like do renal. Then I could talk about tumor staging, renal artery stenosis, FMD, hematuria, vascular malformations, or doing pancreas, talking about neuroendocrine and talking about adenocarcinoma, cysts, parents of cystadenomas, relationship of vessels to surgical planning, to surgical staging. So we'll do this over the next couple of months. So I think it's very important. Also, as I mentioned, and we never get responses, if anyone has any good ideas of what we should speak about or talk about, I can see my Larry David poster in the background. I saw Larry David what was that thing called? Fish in the Dark. He was on Broadway a couple of years ago. I guess probably a lot of people are watching Larry David because with this binge watching, you can watch 10 years of Curb Your Enthusiasm in a couple weeks or a couple days, probably 25 minutes, 10 episodes a season. That's 300 minutes. That's 5 hours. You can be overdosed on Larry David. But I think if you have any good suggestions, so as Larry would say, we're trying to keep things going pretty good. Here's one last question. Okay, is the CT pulmonary angio, would you begin from the bases? We do begin at the top of the lungs and go straight down. In the old days, we would start at the bases when scanners were slow. If you have a 16-slice scanner, it's better to scan from the bases because then there's less motion at a very critical area, and there's always less motion in the apex no matter what. But with fast scanners, we've not had any issues, so we start at the top and go down. But if you think the patient is going to be uncooperative, I would start at the base and go up. It's a much better way of doing it. So with that, we're at 21 minutes, and I guess I've been here, and hope everyone's doing well, as I said it from the beginning. Any questions, solutions, ideas, let us know, and we'll be back next week. And again, 3 o'clock on Zoom today, and we'll see you then. Bye-bye.